I want to first thank Kathy for that really fantastic introduction and for an awesome example of how to present something in a scholarly manner. That was a really nice background that she gave there with all of the history stuff. So I want to switch gears a little bit because I know we have some non-academically focused people in the room. I know there's some clinicians among us and some folks who are not even necessarily in academia at the moment, although you may be considering collaborating with some folks in that area. And I want to talk a little bit about what scholarly activity is and can be in different contexts. And there are three sort of basic principles around which we try to shape scholarly activity: documentation, peer review, and a basis in evidence. And I'm going to go over each of those sort of individually and talk about what they mean, because for different people in the room, they may mean different things. For those of us who work with the justice system, evidence may have multiple different meanings, and we want to clarify how that operates in a scholarly context. So when I say well documented, I think that Kathy gave a beautiful example using the ACE study. The ACE study is a tremendously well-documented and well-rooted study. And you can actually go to, if you just Google ACE study on the internet, you can go to their website and see their dozens of publications and really follow, particularly on the website that they have for the ACE study, you can actually take the ACE evaluation for yourself and see how many hits you have in there. And they have over 17,000 participants in that particular study. So they really make very transparent how they gathered the information and what they were assessing for in looking at the backgrounds of all of these patients that they evaluated. So you can really see from the very beginning, when they began, how they progressed through their study. And that's one of the key pieces in developing any kind of scholarly activity, is write it down. We have a saying in nursing that if it's not documented, it's not done. And the same is true with scholarly activity. If you don't write down and trace out what you did, and I'm winking at my doctoral advisor there in the back of the room because she was always saying, did you write that down? Did you write that? I'd call her and I'd say, okay, I'm going to change this question on the survey because it's not working. Did you write that down? So that when you go to prepare your publication or you go to present your findings, you can say, this is what happened. This is how it came together. When we talk about being peer-reviewed, this goes back to what Kathy talked about disseminating the information that you have. So what's the first thing you do when you finish writing a paper, other than have a drink?
You give it to somebody else to get their opinion on it.
You at least have somebody take a look at it and make sure you didn't, type any curse words or something in there, right? So even on a very minor scale, even if you're just writing a letter of recommendation for somebody, we all go through peer review. You give it to somebody who knows something about what you're doing, or somebody who may not be even in your field or know anything about what you're doing, but whose ability to write and or edit you respect, and you say, can you please review this for me? So that's the second phase. Once you've sort of worked your way through what you're going to do and set up your plan, you want to go to someone else and say, am I doing this right? What have I not thought of? What questions arise for you? And that's the same process that your paper's going to go through when you go to prepare a publication and send it out. That peer review, believe it or not, those people are not as scary as they may seem when you get the comments back. They're folks just in your field, people just like you, looking at your work and saying, this is what we think of it. Now, evidence-based is the last point that's on this slide, and I want to again hit the ACE study on this, because the ACE study is deeply, deeply evidence-based. It started out from medical record review, essentially. Dr. Felitti and Dr. Anda working kind of independently, going through medical records and discovering all of these things, finding things that their patients had in common and beginning to centralize that information. So when we talk about evidence-based, we don't necessarily mean, for the forensic nurses in the room, we don't necessarily mean the evidence that we can collect. We're talking about what we can show, what we can then show from that. And it's a similar principle, but when you think about evidence, the evidence is going to be that you've collected some data somehow, whether you collected it by a survey, whether you collected it by a windshield assessment, if you drove around and looked at the community, whether you performed a certain series of exams on all your patients, or you performed an experiment. You, again, want to document everything that you did so that you're gathering evidence, collecting together information on outcomes. And for folks who are working with community agencies, this is an especially big point. As medical professionals, particularly in the realm of violence and abuse, there is a wealth of information out there that has never been documented or collected. There's lots of community agencies that are working on these things and doing interventions and providing direct services that have never collected evidence, have never collected outcomes or done any kind of evaluation science. And so if we can partner with those folks who are having success in their communities and figure out what it is that's successful, this is maybe something that we can replicate and thereby expand our own knowledge. Am I going too fast? I have a tendency to do that, so wave at me if it's happening. Okay, what button do I push?
The right.
Oh, yay, okay. So in talking about peer review, when we generally say peer review, what we mean is it's published. Where is it published? That's going to be a more interesting question in just a minute. But it's also available for critique by experts in the relevant field. And in order to get it, to make it available that way, it's going to have to be available either in a publication, in a book, some kind of scholarly place where people are going to know to look for it. So for example, if you are a nurse working on the epidemiology of giardiasis in a particular community, you're not going to want to publish that in the local newspaper. You want to publish that somewhere where people in other communities working on similar issues can get access to it and look at it and go, oh, look at that, it's clustering there too. So you want to move things around. You want to continue disseminating your work and getting it out there. This is not always easy. Peer review does have its drawbacks. And one of the points we wanted to address here is the proliferation of peer-reviewed, in parentheses, minor journals. Anybody ever hear of the Journal of Inchworm Science? It exists. I went and tried to find the absolute most obscure thing I could find. There's a lot of peer-reviewed journals, and I'm sure that in each of our professions we could rattle off the ones that we know. Like in nursing, we know that everybody knows the Journal of Advanced Nursing, and everybody knows, if you're an OB, you know JOGNN. Have to get all the letters in there. And we all know the British medical journals, and we all know JAMA. All of these things, that are fairly common. But if you're publishing, and those are the big ones, right? Those are the ones we would all dream to publish in one day, maybe. Effective and useful feedback. Somebody may say, this stinks and here's why. But if that helps you move your research forward, that's what's important, yes? So peer review has its drawbacks. We try so hard to get everything into peer-reviewed journals that sometimes we end up way off in outer space. And we don't get our research where it needs to be. And that's part of the reason we're all here, so that we can connect with each other and start figuring out how are we going to get things into the appropriate forums and what are the appropriate forums for each of our work. Peer review does not always mean correct. If you publish an article with a hypothesis that says the moon is blue, and you publish it in the Journal of Scholars of Blue Moonness, that doesn't always work out so well. The article may be very well received, you may get excellent reviews, but again, you're preaching to the choir, correct? You don't necessarily get the information that you need to move your work forward, and you don't necessarily get the kind of feedback that influences how you develop your program of research and your program of scholarship. Any other thoughts on peer review before I talk a little bit more about evidence-based work? I think that peer review is pretty straightforward. The trick is figuring out who are your peers, especially for those of us who are sort of early on in our careers, figuring out who your peers are and whether or not you're asking the right people to review your work. In terms of talking about evidence-based practice, these are sort of the standard 5 grades of evidence. And if you Google this, you will get lots of nice tables. And there is actually a website that I wanted to give you that's cebm.net, where you can look at the tables of evidence grades. Don't look at the first one. Look for the one that's called Grades of Evidence Table 2. It's much easier to read and much clearer for those of us in the clinical sciences. So anybody who's had some basic kind of quantitative research training probably knows that these go from the top down. So properly randomized controlled trials. This is sort of the gold standard for research when you're doing especially clinical type research. The randomized controlled trial where you have 2 different groups and the groups don't interact and everybody's assigned a number and some get the intervention and some don't. You have a control group that doesn't get any intervention at all. And that's how that's one way of testing a particular type of intervention. And that has been called the gold standard, well, for a really long time. Controlled trials without randomization would be the grade below that. And again, that's the control group where you have people who don't receive anything different than the standard, but you're randomizing other people to different kinds of interventions and experiences and seeing whose result changes the most depending on what you're studying. The cohort or case-controlled study, again, you have groups, but this time without randomization. Studies using multiple time series data, here we don't even have any kind of control, okay? In this case, you're just studying something over time. And finally, studies that are based on the opinions of respected authorities, clinical experience, or reports of expert committees, whoever those are. So, anybody want to venture a guess at what's maybe wrong with this schema, particularly in our field? Charles, do tell.
That's when you first talked about evidence, I was going to raise that very point. The problem I got told this, and I think I told Dave this story, when I first started office, did my first big poster presentation to the National Society talking about the epidemiology of late life domestic violence and social and other things. The person came up to me and said, well, Charles, this is great work, but you can't do your career. Where's the randomized control trial? Which is the standard. I think for our field, I don't think anybody here is going to propose a study where you randomize people to violence with nobody. See what happens. And so that's where a lot of us hit the wall sometimes in terms of convincing folks to support us.
Mm-hmm. Yeah, so even when we do an intervention, you can't have a control group that's clean. You have to have, maybe what would be considered current standard of care versus the stepped up intervention. And it's very hard to show a difference. It's also hard to follow people long term that have been, and so there's a lot of issues that go along with it.
And Dave is raising an important issue with for all of us in this room, we're aware of the statistics about experiences of violence and abuse, yes? How likely are we going to get a clean control sample? I mean, just in my own work, I particularly study intimate partner violence among dating adolescents. And just in my own work, more adult women that I know have come up to me and said, I never realized that was abusive about their teenage relationships. And so they had experiences similar to the folks in my study, but never identified themselves as having been through an abusive relationship. So the possibility of getting a clean control sample, that would be incredibly difficult, and I would love to meet those people. So you can see where we start to have some difficulty when we start to go presenting our work and we start to go looking for funding. People are saying, somebody said, where's the randomized controlled trial? How are you going to make a career out of this? Are you waving or just... Can you speak up? I can't hear a thing over this air conditioner.
It's the cost of randomised trials to get the healthcare response to domestic violence. So it's not a randomised control trial. We're going to have different practices. Respond to violence, whether that affects how many women you identify and how many that you can refer on to advocacy agencies. So there is kind of some ways of...
Yeah, now I think that's an excellent example, but what you're talking about is actually studying the practitioners. Is that correct? Yeah, so we can study ourselves in a randomized control trial where we use different screening methods to identify victims and survivors, but it would be very difficult for us to actually study the experience of violence and abuse in a randomized control type trial. Any other thoughts on that? Anybody have any questions?
The only thing that I'm thinking is, and it's probably not scientific at all, so you'd have to have a very long-term study looking at over the lifespan comparing those who were not abused and looking at their health issues and what the differences were. And then perhaps bringing in the ACE factors.
Absolutely.
And looking at how that would work. But we're talking about something of the order of the Women's Health Initiative study that takes, or the Framingham study It just takes years and years. But if you were ever going to have an effect, now would be the time to start.
Yes, that's an excellent point.
If I can just make a comment about that, because that's perfect. That's why these are so hard. But the National Children's Study is a perfect venue now. Whether they let us treat violence or not.
That's just there to talk about.
Yeah.
The problem with those studies, and I've been involved in Women's Health Initiative, the Jackson Heart study now, the Southern Community Core study, the Hispanic epidemiologic population study. The problem with those studies is the people who run them have a limited budget and a defined amount of data they can collect for that budget over the time period. And convincing them that, so even in my case, letting me add 5 questions is a daunting, I'll say daunting undertaking. Because that drives up a cost to that study over 10 years. So, you know, $50, $100, $200,000. And fortunately, we now have the ACE study that allows you to make the argument that this is important.
Exactly.
But until then, we couldn't even make the argument that it was important enough for me to make that investment. I'll let you answer that.
So just because that was such an excellent segue, I'm going to jump to the next slide and talk a little bit about the pitfalls of requiring evidence-based documentation and publication information. Requiring too high a level of evidence. So thinking back to the previous slide, that randomized controlled trial, the idea that we might be able to publish something like that around violence and abuse, that's pretty elusive. We can figure out, as our colleague from the UK pointed out, we can figure out ways to maybe study with practitioners, but there's no way we can figure out how to do that with our patients. Requiring outcomes data when the outcomes are too distant from the intervention. This is what we were talking about with the Women's Health Initiative and these very long, you know, when is it going to produce some data? When is it going to produce some data? Trying to figure out how to define intermediate outcomes and seeing something before we've finished the entire project, seeing whether there's a trend, seeing whether we've changed any statistical knowledge that we have about how things are discovered and how things are sorted out. And then letting the perfect become the enemy of good. And this is one of my big problems, personally, as a researcher, is trying to get to perfect, trying to get to the ideal intervention, trying to get to the ideal array of services, the ideal screening tool. That it's just never going to happen. There's always going to be somebody who's going to say, but what about? Or what if? Or how does, you know? And so sometimes we can get so caught up in trying to tailor things exactly that we forget that sometimes it's good just to get it out there and say, wait a minute, this happened. When I'll tell a story about myself. When I was working on my dissertation research, I was looking at young adult women who had been in abusive intimate relationships as teenagers. And I was looking at their health outcomes around depression, suicidality, engagement in risky behaviors, and an array of things. And I finally had gotten all the data entered, and I was finally getting to do some of the statistical analysis. And I used the BDI, which is a depression instrument for those of you who aren't medical folks. And I ran the statistical analysis on the data from the BDI, and they were depressed. And I was so excited that they were depressed. And then I was not so excited anymore because that was the first sort of time that anyone had said, okay, here is something that happens to people in adolescence, and here is something that is happening in adulthood. So I kind of followed, the ACE study was my inspiration. I kind of was following along to see, okay, what other kinds of things are happening? And where is this starting to happen? And how is this experience different maybe from people who are abused as children or people who are abused as adults? So when we start looking for long-term outcomes, when there isn't any long-term data to be had, that can impede our ability to get published. That can impede our ability to share what we found. And so looking for something a little more intermediate. So I looked at young adults, most of whom were relatively healthy and who didn't necessarily have the kind of chronic conditions that Felidia and Anda talk about, but I still could show, okay, here are some health problems that are emerging in this population following this type of experience. Anybody else have any thoughts on that?
Yeah. The last one, letting the perfect become the enemy of the good, is the whole issue around U.S. Preventive Health Task Force recommendation
Mm-hmm.
that screening
Yeah.
shouldn't be part of the typical practice for domestic violence.
Mm-hmm.
It's that we don't have.
Does everybody know what Dave is talking about? I just want to
we
make
don't
sure
have
that everybody in the room
perfect
is clear
evidence
about
to show
this.
that there's good outcomes.
Yeah, so there was a recommendation issued against screening for violence in primary care. Right. Right. Yeah, it wasn't so much a recommendation. Yeah, okay, let me rephrase that. Not so much a recommendation against screening, but just saying that there was not good enough or sufficient evidence to endorse universal screening.
I just had a couple of thoughts about the last thing that we said, that they were depressed or they weren't depressed. But, you know, when you think about the ACEs, and we know that we have an intervention, if you will, the ACE in childhood, and then years later you have the outcome. But another question would be, when does the outcome first begin to appear?
Exactly. Exactly.
So you don't have to take it all the way out.
Yeah.
You can say that if a child, for example, if a child is abused at the age of 10 and then begin to manifest certain behaviors or certain health outcomes as their teenage years, you can then go to the pediatricians or the adolescent specialists and say, you know, this is what you need to look for.
Mm-hmm.
The other is, there's a saying in the self-help community about progress and perfection. Do you know that? It's progress, not perfection.
It's progress, not perfection.
You just have to build.
Mm-hmm.
You don't have to be
Exactly.
at the top. You just have to make the stepwise.
Exactly. And especially for those of us who are early career folks or people who have not yet, decided exactly how they want their career to progress, this is exactly the kind of thing that we need to be thinking about. And this is what I hope you're going to take into this next breakout session and start thinking about. How might you begin to collaborate with folks in your area, or how might you begin to collaborate with folks in your community to start building some kind of project from which you can embark upon a career path working around violence and abuse. And this is what I'm hoping everybody's going to kind of take into the breakout session and start thinking about how do we develop these projects. And I'll just, hello, yes.
I'd be remiss. I'm the advisor she alluded to. So I'm taking my stature for the interview. I'd also say that sometimes a place to start is to do a qualitative study, which actually documents what we've all been seeing in our clinical practice.
Yes.
And actually brings the stories to life, because those can also be very compelling. And sometimes they can engage people in a way that a number on a certain scale doesn't. And of course, it doesn't provide the definitive evidence, but it can be a good, sometimes an inexpensive way to start developing a program.
Absolutely, yeah, and thank you for getting me to my last point rather succinctly, which I just wanted to talk about in terms of letting the perfect become the enemy of the good. One of the first things we do as doctoral students is we start looking for a gap in the literature. We start looking for the thing we don't know anything about yet and trying to fill that gap. And qualitative research is sometimes the best way to start bridging the gap and building a scaffolding around the edges from which you can start to develop a research project. So if there's something out there and you really don't understand it, qualitative research can help you get at the story of it, the essence of it, finding out what is that experience. And then maybe once you've seen it, because it can be very different, the lived experience of a thing can be very different from the clinicalized experience. So for those of us who are clinicians, what we see when we're trying to treat a patient may be very different from the way that the patient is experiencing that phenomenon. And finding that out is a very important piece toward filling the gap and getting past perfect and into good. So as you go into your breakout session here, and I think how many minutes did we say for this one? 15 minutes. And then after that, we'll take a short break, let everybody get up and stretch. As you kind of go forward, start thinking, where is a source of some information that I can get at? What kind of information am I interested in? Who can I work with? So I hope that'll be what you discuss in your breakout. So we have 15 minutes.